Hello, everybody. My name is Curtis Wilkerson. I'm an incoming medical student, and welcome to the Physician's Mind podcast. Today, I'm honored to be speaking with Dr. Clarence Nicodemus. Dr. Nicodemus is a highly accomplished individual and an experienced, board-certified neuromusculoskeletal medicine specialist. He graduated with honors from Michigan State University College of Osteopathic Medicine at 62 years of age after a 25-year career as a biomechanical engineer. He completed his residency in neuromusculoskeletal medicine and then practiced independently for 9 years. He was a member of the Board of Osteopathic Physicians and Surgeons of California, and he has a previous career of 25 years as a biomechanical engineer. He earned his BS, MS, and PhD in engineering with specialty in orthopedic biomechanics from UC Davis. He was an engineering consultant to the California Department of Rehabilitation, and he was later employed as a principal scientist and manned systems department manager at NASA Johnson Space Center in Houston for 6 years. Dr. Nicodemus is the clinical research director for the Osteopathic Manipulative Medicine Department of the MSU College of Osteopathic Medicine. His research focus is in understanding the common causes and optimum treatment of chronic low back pain, which is the goal of our discussion today. He is investigating the role of sacroiliac joint dysfunction as a major cause of chronic low back pain, along with the myriad of other musculoskeletal symptoms that accompany it. His research includes clinical observations and trials, as well as biomechanical laboratory studies into the role of the sacroiliac joint in the mechanics of lumbosacral pelvic motion, as well as force transduction across their unique structure. So, Dr. Nicodemus, how are you today? Thank you for being here.
I'm just fine, thank you. Good to be here.
All right. Yeah, you have a very impressive resume, and I'm excited to get into this discussion here.
Thank you.
So I think we're going to begin just by looking at one of your main studies here. The study is titled Revisiting Chronic Low Back Pain, Evidence that it is Nonspecific. Now, what do you mean by nonspecific?
Well, I don't use the term, and the term is generally used in the literature and actually worldwide to describe the kinds of chronic low back pain that do not require surgeries or have anything to do with spinal fractures or conditions of the spine that require surgical investigation or other things. They're the sorts of issues that develop other than those critical areas. And so the term has been applied to it, nonspecific, meaning presumably there's no cause for it, and therefore it makes the treatment more difficult and so on. And that's just simply not true.
So essentially you have discovered that there is a common origin for most chronic low back pain.
There is. And it's quite evident once you treat a number of people. And I think the other day I was asked how many people I had treated over the years, in approximately 20 years that I've been doing this. And I think I'm around 3,500 or so that specifically have this disorder. And so I have some ability to judge based on observations I made over that number of patients over time.
Okay. So we have some firsthand experience, and also we have some statistical data to support this.
Yes.
Now, I'll go ahead and read just the abstract of this paper here. For the context, there is a common symptom pattern with most chronic low back pain, which you mentioned, suggesting that there is a common underlying etiology, belying the term non-specific. Many studies of chronic low back pain and its treatment have been conducted with the assumption of non-specificity, and as a result, the treatment has not been focused. Thus, there has not been a significant change in chronic low back pain prevalence over the last several decades. And your study basically showed that there is an underlying specific cause of chronic low back pain, and that the presumption of chronic low back pain being non-specific is misdirected. So can you expound on that idea and how it relates to the lumbosacral pelvic region, the sacroiliac joint, and the overall neuromusculoskeletal system?
To clarify, I'm not proposing that I have found the cause. What I've found is high correlation with sacral dysfunction and the presence of a number of pains, tissue pains that patients complain of who have this, what I refer to as chronic low back pain syndrome. And what I mean by that is virtually without exception, in my experience, treating this number of patients over the past years, very few of these patients do not have a sacral dysfunction. They do not have conditions that, well, let me rephrase that. They do have other pains that they complain about. And it's a constellation of pains that's quite common and predictable. So they're going to have usually a groin pain of some sort, either one side or the other or both. They're going to have a sharper pain in the low back, which is not centered. It's to one side or the other or both. And these are the locations typically of the iliolumbar ligament. And as that ties into the posterior sacral ligaments. So those are going to be tender to palpation. And in addition, they're going to have one or both iliotibial bands, the lateral aspect of the thigh, and in addition, one or other of the hip adductor muscle group inside the thighs that are going to be sore. So these tissues that, when palpated on the patient, will be reported as tender, sore, varying degrees depending from patient to patient, but they will be present at some level. The paper that you're reading from cited the statistics related to that kind of correlation between presence of an SI joint, a sacroiliac joint dysfunction, and the presence of these other tissues. So it's a very high correlation. It's not causality. It doesn't prove the case that an SI joint dysfunction is the cause of these conditions and therefore the chronic low back pain syndrome. However, whenever a person comes in with chronic low back pain and to test my hypothesis, the only thing that I treat is the sacroiliac joint, one or both, whatever is, and whatever else is within the lumbosacral pelvic structures that needs correcting, and then provide some home exercises, just a couple of simple ones to stabilize the region. The pain in these other tissues diminishes, pretty much reduces or goes away completely. And so if one can, in a sense, verify the hypothesis by treating that part that you're saying is the cause, if you, in a sense, fix the cause and the problem goes away, it pretty well confirms the hypothesis in my mind. That's not scientific proof, but it's a clinical proof in a sense. And that's where I come to today based on my experience.
Okay, so essentially you've discovered that there is a strong correlation. Correct me if I'm wrong here, but you found that there's a strong correlation between sacroiliac joint dysfunction and pain or tenderness or other issues in the surrounding bilateral structures.
Yeah.
Such as the lower back on either side or the IT band or within the groin or what have you. And you found that with your treatment method to resolve the sacroiliac dysfunction, you found that it can resolve these issues with the pain in surrounding regions.
Correct.
And thus you have come to the conclusion that perhaps there is the common cause to chronic low back pain, which could lie in SI joint dysfunction.
Yes. And therefore, going back to the title, it's a question, the idea of calling this non-specific, because the problem with that, and it was a phrase that was coined 40 or more years ago to try to differentiate between the two groups of back pain. That is the ones that require surgery related to the spine and so on and so forth, and those that don't. Those that don't have the so-called red flag issues. And so, unfortunately, that term is stuck. And the problem with it is that words matter. And when one is trained around the idea that there is this thing called non-specific chronic low back pain, well, that implies or gives the connotation that, well, there's really no cause for it. It just sort of happens, and so it's hard to treat, and so there's no, uniform approach to it. And so what am I to do as a provider to treat this. I just basically throw up my hands and turf it off to somebody else and see if they can fix it.
Mm-hmm.
Well, that's what's going on in healthcare profession, is that specialists, family practice, primary care type, and, others who typically treat chronic low back pain approach it in this manner, that it's a multivariable problem that is very difficult to solve and whatnot. And in reality, it's not. And what that has done is to shun away, funding for targeted research and so on that would more effectively define the problem and therefore produce a more reliable solution to helping these folks.
And basically, because of the misunderstanding of the origin of back pain, like you said, it has diminished the approach to care generally, and it has prevented more research from being done.
Yes. For example, the typical trajectory of a patient who experiences this, they'll go to a primary care physician. They'll identify the fact this is a chronic low back pain. In other words, we're talking about back pain that's lasted more than, and it varies, but more than, let's say, 3 months.
Yeah.
Most back pain, acute back pain, will resolve itself 6 to 8 weeks or so. That's a strain or sprain and that sort of thing, and it'll self-resolve, just like any other sprain or strain in the butt. If it lasts longer than that, it goes into the chronic realm, and it means that there's something else going on besides a sprain or a strain. So when presented with that, a primary care physician, or now there's a lot of nurse practitioners and so on who see these patients, they'll say, well, maybe they'll try a bout of medication. They try some Aleve or non-steroidal anti-inflammatory. Get some rest. We'll see you in 5-6 weeks, see how you're doing. So if it doesn't resolve, then they'll typically refer to a physical therapist who will apply their algorithm for chronic low back pain, which is typically strengthening the core, which is a good approach, with the caveat that there are some contraindications there that are oftentimes overlooked, which are reflected in those findings of the tissues that are tender on most of these patients with chronic low back pain, specifically in the groin or the hip flexor muscle, psoas muscle. If that's tight, chronically tight, contracted, and sore, then there are some core exercises that will produce increased back pain, not reduce it. So in general, core strengthening is good, but with cautions. Okay. So oftentimes, due to that lack of complete understanding about the issues, it doesn't work well. The PT approach and protocols don't work really well, and the patient goes back to the primary care, says it doesn't work. Okay, what do we do now? Well, right, let's go to pain medicine. Let's just see if we can get you out of this pain with injections and other sorts of approaches. And that's fine, except it's temporary. I mean, it's masking the problem, helping with the pain, which is good, but it's masking and not solving the root cause. And so then if that doesn't work, at least in the long term, it won't work, then sometimes they'll go to a surgical referral, a spine surgeon referral, to see if maybe somebody missed something along the way. Is there something in here that might be approached with surgery? A good surgeon will recognize the fact that it's not a surgical solution and say, well, no, we can't do anything here. Let's kick you back into the cycle somewhere. Oftentimes, most often, it goes back into physical therapy and so on. And so the patient is going through a lot of different trials to solve this problem, passing a lot of time in pain and dysfunction and getting quite frustrated. And so there are psychological problems that develop. Their pain becomes part of their story. Maybe there's a problem with the addiction on opioids and so on and so forth, if they get prescribed along the way, because time now is a long-term thing. So that's kind of the milieu that we see the chronic low back pain patient involved with. And that's why there are a lot of people that look at from that perspective and say, wow, this is really a difficult problem. We have, it's to deal with many complex factors, psychology and everything involved in this. Well, the psychological picture doesn't get developed until there's pain over a long period of time. If there's no pain, there's no psychological problem. So let's get to the source of the pain and eliminate it. And then we don't have the psychological problem. So in any event, my point is, if I could wave a magic wand and teach the world how chronic low back pain works, as I understand it, and how to treat it, we eliminate that whole cycle for those patients and the cost associated with it. What it takes is some knowledge of manual medicine, that is, how to resolve the sacral dysfunction, and then a supervision of that over time with exercise as the body readjusts and readapts to the now normal situation. But, that's the program. That's the protocol. Simple, not complicated, and effective.
Absolutely. Of course, as you mentioned pretty thoroughly, there's numerous, it's basically a chain of negative events that comes from the incorrect approach to chronic low back pain. You mentioned how the physical therapy treatment for back pain may not work well, then the physician may lead to prescription of pain medication, and then as time goes on and on and on, the patient develops a narrative about their identification with their pain, and so on and so forth, and it just leads to a milieu of problems that could have easily been avoided with a different approach to the patient's care. So I understand why this is important information, why this is something that we should be thinking about. What do you think are some of the barriers to spreading this information, first of all? And I suppose once we answer that question, we can go into when a patient comes into your clinic with complaints of low back pain and you get a history and whatnot, what is your approach to that individual's care?
Well, two big categories of discussion there. The first part, the barriers that's one barrier. It's education. Unfortunately, and I'm judging, I haven't been to all these schools, but judging from their product, many providers who ultimately will treat chronic low back pain, as they're taught in their schools, are taught this non-specific model of chronic low back pain. That is, they're taught, well, it's a really difficult multivariable problem. So, just kind of do your best to treat the symptoms, and then if you can, move them on to somebody who may be able to help. That's what the provider coming out of the medical school, the physical therapy school, the PA school, the chiropractic school, and every other school that produces a provider who treats people with chronic low back pain, that you do the best you can, but it's hopeless, and you just basically do your best you can. And there's no solution to it, just move on. Well, that's the biggest problem. That is compounded by the fact that if, as an interesting trial, if anybody wants to try it, is to go to the website of the National Institutes of Health, and on their very first home page, you have a block where you can ask a question. What's your question? So if you type in, what are the causes of chronic low back pain, you will get back a page or two which summarizes what collectively the Institutes of Health think are the causes of chronic low back pain. There are about a dozen that they list, and they're all spine related. Well, when one treats chronic low back pain in a professional capacity, and people come in your door with it, percentages of patients who have spine-related chronic low back pain problems run about 15% out of the total. In other words, 85% are not spine-related. And yet here in our Institutes of Health, we're saying, here are the causes of chronic low back pain. And in reality, that's only 15% of what causes low back pain. they don't address what I consider to be the cause, which is it's a neuromusculoskeletal problem that's easily to solve, and instead it refers to all of these spinal issues. Well, if you then take that list and you sprinkle all the monies that NIH has to spend on research, you can see where it goes. And it doesn't go to the areas that should be studied to be effective in understanding this problem. So that's the problem. Now, I've forgotten the second category already.
So the second question was basically, now we've established that this is an important method of treatment, an important thing to consider in the treatment of chronic low back pain. The next question was basically, can you illustrate for the audience what your approach is when you're evaluating a patient who's complaining of chronic low back pain?
Sure. So the way that I evaluate patients that come to me as a new patient is I want to hear their story, in the sense, tell me what you experience. It's quite interesting. Most patients, when they come in, having been through this cycle of, PT and then pain management and orthopedic surgery referral and so on and so forth, they'll come in to me, and when I ask that question, tell me why you're here, what's going on, they will give me a diagnosis. They'll say, well, I have a L4-5 disc that's causing a radiculopathy, and so on and so forth. And it's like, no, that's a diagnosis. I want you to tell me what you feel. It takes 3 or 4 times to get them to actually say, okay, I feel the pain here, I feel the pain there. And with that, where do you actually feel the pain? They'll put their hand somewhere and say, well, it hurts here. Well, that's a big territory, wherever it is. I want you to be more specific. With one finger, show me where it hurts. And extremely reliably, they'll put their finger right on the iliolumbar ligaments to start with. It hurts here, either here and here, left and right, or one or the other. And so I know right off the bat, we're dealing with, typical chronic low back pain. They don't point to their spine. They don't. There may be some issues going on with the muscles around the spine that get involved, but they are secondary to this, pointing to these areas on either side of the spine where the ligaments lie. And then they'll go down. If you help them along the way, does anything else hurt? Then I'll go into, where are these things? There are a lot of questions about their history. How long has this been going on? What's the severity of the pain? What's the quality of the pain? Is it sharp? Is it dull? Is it continuous? Is it intermittent? Those kinds of questions to understand what it is they're feeling. And so you get a sense for what tissues are causing this. Nerves have one type of pain, muscles have a different type of pain, and so on. So I also want to know what kind of dysfunction this causes. That is, both from the standpoint of what makes this worse, under what conditions does this aggravate this pain, but also from the standpoint of what can you not do? What does this keep you from doing at home or at work or anywhere else? So those kinds of pictures that they draw about themselves help understand about the entirety or the involvement of their body with the syndrome. In other words, if it's just started, it's very local, doesn't affect much of what they do. As time goes on, inflammation increases, pain, the pain volume increases. It affects more of what they do, and so it becomes more of a larger aspect of their life, and so on and so forth. So it try to understand really how long and how involved this condition is to them and how long it's been there. Inflammation is a big part of this. As with all injuries, inflammation is a is a component. It's part of the healing process, and we understand that. But it also sensitizes pain sensors in the area and the surrounding area. And what I mean is, if there is inflammation caused by ligaments, caused by painful muscles, caused by a tendon where they join the bone, attach the bone, and so on and so forth, any of those areas with time will become inflamed and will seem like a much larger area just because of the inflammation. And so that's a component that we have to deal with. But those are the things that when a new patient comes in, before I even put my hands on them anywhere, is to understand what it is they're dealing with as they perceive it, and so that I get some sense for how sensitive they might be, how difficult it is for them to move, and so on and so forth.
And so once you understand their perception of the pain, does that allow you to approach your subsequent treatment in a different way? Like, are there certain perceptions of pain that lead you to think of different approaches here, some different techniques, or is it generally coming back down to the same idea? And because you said most of them tend to have, it was the iliosacral, what the ligament that was most commonly pointed?
Iliolumbar
Ligament. But you're evaluating their perception of the pain, and of course there are going to be some cases where it actually is a spine issue. But you said the majority of these are in relation to the SI joint. So now, once you've established, okay, how are they perceiving their pain? What's next? Is this when we're moving into the manipulative treatment now?
Okay, so let me clarify. I'm not talking any of these patients I'm talking about have already been screened for the red flag items.
Okay.
So none of these people have any issues like fractures, like spondylolisthesis or slipping of one vertebra on another, or they don't have necessarily a disc bulge that's impinging on a nerve, causing a verified sciatica and all those kind of things, because those must be dealt with another way, not through manipulation like I do.
So these are the guys that have basically been, the ones that you're talking about are the ones that have previously been written off as the non-specific group.
The ones that I deal with, yes.
Right. Okay.
Yeah.
Okay.
The other ones, they need to get other specialists to work on that spinal issue. Okay. Now they may come back to us because very often there are a combination of things going on, but when they reach me and I'm dealing with them, they don't have those issues. So I don't have to. I'm aware of, and I'm continuously monitoring to see if maybe somebody missed something for them that I want to make sure and catch. But I'm not purposely screening for those things at this point. Okay, I've got the 85%. In other words.
Right. Okay, that makes sense.
Yeah.
So once you've established how they're perceiving their pain, what is your manipulative technique?
Okay. Their perception of their pain varies wildly. The same pain condition in 10 different people will be reported 10 different ways. It's just human nature. It's based on their experience, their neuromusculoskeletal makeup, their personality, whether they were abused or not as a child. All those kinds of things play into how a person perceives pain. So from person to person to person, the report of pain varies for the same condition. So you can't depend on their reporting for an accurate portrayal of what's actually going on. And we have a saying in osteopathic medicine is we don't chase pain in our treatment. We don't necessarily go to where the pain is to, quote, fix it. The pain can come from a variety of different sources, not necessarily co-located with the problem, with the cause. So what I'm trying to do is to understand how they feel about their own situation. That's kind of independent of my evaluation of what's going on, but it's an overlay that I need to be aware of. So then I go into an examination. Well, there's an intermediate part too, where I have reviewed any medical records that they have, any recent surgeries, any conditions, comorbidities. Do they have a diabetic patient? Do they have heart conditions that lead to, conditions that will prevent them from doing exercises and so on and so forth? So I need to understand also what the rest of the total person is experiencing and dealing with, what medications they're taking for these conditions, to see how they might interact with how they perceive the pain and how they're able to move, how it affects their nervous system and their neuromuscular system and so on. So once I've got all of that analysis out of the way, then I go into my evaluation, which is, for me, it's a focused exam. We have what's called an osteopathic exam, which is a complete full body exam of everything. For me, I do a focused exam on essentially the lumbosacral pelvic region, initially anyway. So I'm looking for asymmetric inominants, for example. Are the hip bones symmetric or not? Because that's the first indicator that there is a dysfunction in that structure. Now, I don't view, this gets into a more complicated description of things, but I think we're wrong to try to understand on a joint-by-joint basis where the problem is. And what I mean is it a SIJ or a sacroiliac joint that's the problem? Or is it a lumbar spine problem, L4-5 problem? Do I see a dysfunction? And does that solve the problem? And the reason I say that is this lumbosacral pelvic region, it's a structure that is the foundation for the body and its movement. And what I mean is the pelvic ring, made up of the two innominants and the sacrum, that acts in a way as a foundation. It's not, unlike a house, it's not the bottom of the whole thing. It's where the center of mass is, basically. But it's a combination, it's a structure that, first of all, supports the entire upper body as we stand or as we sit. The entire upper body rests on top of the spine, on top of the sacrum. That's the lowest bone in the spine. That, in turn, is supported on each side by the innominants at the sacroiliac joints. So then, as we stand, the support from the legs come up and join the innominants, transmit those supporting forces to the SI joints and to the sacrum. So the whole upper body weight sits on top of the sacrum, then the sacrum is supported by the two iliac innominants. And so the sacrum becomes really the key to the whole support structure in the body. I mean, this is not true if you're swimming, of course. I mean, it's a different picture. If you're on all fours, it's a different picture. But mostly we're either seated or we're standing. And that's where people complain about the problems being, all right? So my description of this is key because in that system, in that lumbosacral pelvic system, there are, depending on how you count them, around 65, 67 muscles attached, one way or the other, from the top down, from the bottom up, and internally there are muscles associated with that. That's a lot of muscle coordination that has to occur when we move. That muscle integration, no matter how we move, all those muscles are involved in one way or the other. And that integration, that sequencing of those muscles is what provides us with the dynamic support that system provides for us. If you jump, there are enormous forces that are generated both when you jump and when you land. It has to absorb all that. It has to, in a sense, when it absorbs it, it's going to be knocked out of place momentarily as it adjusts, and then it comes back into where it's supposed to when we settle down. And that's the way the system's built to work. Well, in reality, under a couple of different conditions, one is under extreme forces, automobile accident, motor vehicle accident, a severe fall on ice or something like that, will knock this system out of whack, use a vernacular, in people of all ages, young people, older people, so on. Then there's another group of folks, the older population, who do not do exercises as they age or exercise less than they used to. They don't maintain the strength and tone in their muscles. And so it takes much less now of an event to set things in dysfunction where they don't go back to where they are. In other words, the muscle control is not sufficient enough to bring them back into so-called neutral, the way that we like to have it, and the way it would have done when they were younger. So we find older population are more likely to have these kinds of conditions than the younger population in that regard. So getting back to my one joint part of this discussion. So it's not just one joint that's the issue. It's a structural system that's not functioning properly. And I hesitate when somebody say, well, what's the cause of chronic low back pain? Is it the SI joint? Well, yes and no. The SI joint is an observable involving piece of that picture, but it's not just that. It's that whole thing working together is not working together the way it needs to. And so it's reflected in the lumbar spine. It's reflected in the muscles that are part and parcel of that pelvic region. So you get pelvic floor pain, you get, and we mentioned the psoas and the groin pain and so on. We get IT bands that are connected up to that thing and so on and so forth. So it's a much larger structure than we typically are comfortable with trying to identify. We try to do a reductionist approach to things and say, well, it's just this one joint, or it's that joint, or it's this, and it's not that. It's a combination. Getting now to follow up on the question you asked me about how do I treat the patient? What's my steps involved in dealing with the patient? The exam goes about identifying all of the pieces of the puzzle. Where are the things that are not where they should be normally, and how that I can have an effect on it. So yeah, the SI joint are one of them. The innominants are part of that. The lumbar spine may be involved with it. And in terms of the pelvis and the innominants, it's not just the back where the SI joints are, but it's also the front, the pubic symphysis. Is there a shear present there? It's a three-dimensional structure, and that needs to be examined all the way around. And of course, we look at other things such as leg length discrepancies. We always ask the question of the patient, have you experienced a fall? Have you experienced a motor vehicle accident or something that could have started all this? And the majority of the time, no, I don't remember anything. Well, then we also have to consider things like a leg length discrepancy as causing some of this dysfunction in that pelvic region. Because if you have one leg shorter, anatomically shorter than the other, you have essentially a constant driving force that wants to distort this lumbosacral pelvic region. And the body adapts to it, and sometimes it's just fine, and other times for their entire life they struggle with this pain because of something that was not evaluated in their younger years. So those are the kind of things that I do on exam. And for the most part, while we're examining, we also do procedures to help return function. We manipulate this way and that way, depending. There's a variety of different approaches to use, and to try to return function as much as possible, and then help the patient with some simple exercises to stabilize things and get them back working the way they would like to be with less pain or no pain. And a short summary, that's the answer to your question.
It's incredible. It's very incredible. I think it really illustrates how important it is, and really it illustrates how important it is to have a holistic approach to patient care. And it also shows how complex medicine truly is, because there's one avenue of approach where, okay, I have chronic back pain, I'm going to prescribe you this pain medication, and we're going to send you to physical therapy. And then you have this avenue of approach, right? You mentioned how you're first going to go up to the patient, you're going to gather their narrative, you're going to find out how they perceive their pain. Then you're going to take a look at their history, see if there's any associated factors that may affect how they can, for example, exercise or how they can perform certain activities or certain accidents in the past or certain medications that they take, all these things that could affect your approach, you have to evaluate first. And once you've kind of finished that examination, so to speak, then you can sort of go into what you call the focused osteopathic exam. You mentioned like there is an overall osteopathic exam, but for your purposes regarding low back pain, you typically, you approach what you're going to be looking for asymmetric innominates. You're going to be looking for the SI joint dysfunction, maybe some lumbar abnormalities, some abnormalities in the pubic symphysis, or even some leg length discrepancies, and then really thinking, okay, where are the pieces of the puzzle that can be put back into place by my methodology? And I do think it's extremely interesting how you discussed the lumbosacral pelvic region and how it really acts as the foundation of the neuromusculoskeletal system, the foundation of our movement, because, the upper body terminates, I suppose you could say, at the sacrum, and then the SI joint is what connects that to the innominants, which is where most of the force is distributed with really like all of our standing movement. A lot of our standing movement, centralized force ends up in the SI joint. So considering all these things really makes you think about how nuanced it is and how difficult it is, and how, as a physician, you really have to approach with adequate knowledge and adequate understanding of the interconnectedness of the body. So that is incredible how I think it was a complex description and there was a lot that went into it, but I think that's just the nature of the topic. I think it requires that magnitude of description in order to really understand the point. So that being said, now that we've sort of established the misconceptions of chronic low back pain, we've established your approach to treatment, and we've established how you look at a patient, what advice would you have for a medical student who's either starting medical school or in the middle of medical school? What advice would you have for a resident or even a practicing physician in regards to this sort of patient care?
Well, for the student and for the resident, my strong recommendation is, if you have an interest at all in understanding these issues, the neuromusculoskeletal system, then learn your anatomy, and then go back and learn your anatomy. Because until you understand thoroughly how things work together, what are the component pieces, not just physically what joint fits into what joint, but muscles attaching to muscles, and then the nerves, where do the nerves travel that reach those muscles? Because there are so many issues around this idea of chronic low back pain, and in this what I refer to as lumbosacral pelvic region, there's so many nerve plexes or branching of nerves that come off of the spine, that come out of the SI joint, the so-called sacral outflow, that go into multi-branched complexes that then exit into things like femoral nerve or the sciatic nerve, and so on. When somebody experiences a numbness or a pain in the lower extremity, for example, the natural inclination is to try to simplify the solution as, well, it must be a surgical solution because it's a nerve pinch going on. Well, there's a pinch going on, most probably, somewhere along the line of that nerve and that nerve's origin, but that nerve going to the lower extremity has multiple origins running through multiple muscle groups that, if those muscle groups are contracted, can cause compression of a nerve, which mimics a pinch higher up in the chain. So what I'm suggesting is, it's not always a nerve pinch at the spine. There's a whole territory through that pelvis that is subject to derangement or to compression of nerves as it exits through that, with muscles being contracted and so on. So I just illustrate that as rationale for understanding all of the complexities in that region. You cannot appreciate what's going on or even evaluate what's going on really until you understand all of the components associated with that. The complexity goes another level when you start talking about the entire system. The entire system includes feedback circuits, includes what the sensors are doing and how they travel back to the brain and to centers within the spine to affect change within that system. And what I'm saying is, when there is a joint dysfunction, sprained ankle, sprained knee, of course fractures, but I'm just thinking common joint kinds of disorders or injuries. Much more goes on than what we think of as locally in that area. All right, in that area, let's take a knee for example. There is embedded in that joint system around that joint numerous sensors. Some are pain, which we can understand. Oh, it hurts. Okay, so I'm getting pain back from that. But there are other things, and there's temperature, there's vibration, there's a variety of things, sensors that we know about that monitor conditions of the body. But the ones that aren't discussed that much are what's called proprioceptive sensors. These are sensors that monitor in a joint. They monitor rotation and movement of that joint. They monitor tension in ligaments and tendons. They monitor length and tension in muscles. And so all of this sort of information is being fed back to the brain. So one can imagine at the brain level, there are multiple centers that deal with this stuff. At the brain level, there's some attempt to fix the problem. Like everything that happens in the body. If you get a stab wound, there's pain associated with it, but there's an immune response. It comes down in case there are any infections involved. You get inflammation. There's a cut. There's a blood clotting response that develops. That doesn't come from the brain. But what I mean is the body tries to fix whatever is broken at the time, to include adjusting of muscle tension around a joint that's been injured. It will contract certain muscles. It will inhibit certain muscles in order to do its best as it understands the problem to try to stabilize and prevent further injury. That occurs at every joint in the body, no matter how big, how small. Well, okay, so then let's apply that to, let's say, the SI joints, if they're dysfunctional. Well, muscles are tightened. The psoas muscle is one of the first ones that gets mentioned. Other muscles have to do with IT bands. The tightening, the tensor fasciae lata muscle tightens up the IT bands. The hip adductors are all tightened as a way, apparently, I'm guessing, I don't have the manual for the brain. So I'm guessing that the approach is to stabilize, to inhibit, to try to prevent additional injury around the SI joints in that system so that it doesn't get any worse. Eventually, that leads to ancillary pain. These are the pain centers that I reported initially when we started that develop because of this kind of activity. There are, across every joint, there are more than one muscle. We need two to activate any joint, go one way or the other way. And these muscles, as we know, are paired neurologically. If one's on, the other's off. Or if one's contracted, the other's inhibited. So we have inhibition that occurs as well, especially in the extensor group around SI joints. The hip extensors get weak. And so we have people's inability to stand very long with this back pain because it tends to, they just don't have the strength. And so that's one area that we want to strengthen. It's part of the core, and so on. But my point is that I really object to people using the term musculoskeletal system. There is no such thing as the musculoskeletal system. There's the musculoskeletal group of tissues that pretty much just lay there on the table and don't do anything because they're not hooked up electrically to anything. So the system is one which includes feedback, which includes the neurology of the piece. So it's got to be the neuromusculoskeletal to make a system out of it. And so in any discussion about injuries and things having to do with the muscles and the joints and whatnot has to include the effects on the nervous system or by the nervous system as part of that whole package. And that's very commonly left out of the whole thing. And the really sad feature is that it's left out from some of the most critical aspects of this problem. Let's take somebody comes in with this is not what we've been talking about, but a whiplash injury. And the person is post-injury and they still have neck pain, severe neck pain that keeps going for months and then years, even though it's treated on a regular basis with injections, with massage, with manipulation, with every kind of intervention that we can come up with. And it still goes on. And we get MRIs and we look at it. Well, I can't see an injury here. I can't see any tissue being torn. I can't see any fractures. I can't see any dislocations. I can't see anything that would warrant that. Well, what's missing is an asterisk by that report from the radiologist, which, if you go down and look at the fine print, would say, but be advised, there are nerves of the feedback type, the sensory type, that I can't see. And those may very well be injured. So take that under advisement. That paragraph is missing. This never appears. And so in our typical approach to this thing is we take a superficial look at all this without understanding the more deeply rooted problem. And so that's why I mentioned that this just gets more complicated. But as we back out of the woods, it's quite simple. We just have a joint dysfunction. The body's reacting to it, causing muscle dysfunction. We manipulate, get things back functioning the way they're supposed to, and it goes back again. But we keep iterating on that, so eventually it goes away with the exercises, and we've solved the problem. We understand the underneath piece of it. We understand how they're related. Joint system causes neural effects on muscles, causes pain. That's where all those muscle pain come from. Understand that whole chronic low back pain syndrome. Great. Okay, now we can fix it, solve the problem. We understand it, fix it. It's not this horrendous bag of worms that's hopeless. And so that's my point.
Beautiful. Beautiful. So for the layman, without getting too deep into it, if someone wants to understand the basics of what we've talked about today, you have a joint that's out of place in some capacity, particularly for low back pain, the sacroiliac joint. It's out of place. The body has mechanisms to compensate for that erroneous placement, to protect itself. The body's reaction to the misplacement is what causes pain, and that pain can be relieved through certain manipulative treatments with occasional retreatment, eventually be restored to its normal state.
As much as we can, yes.
I hope that this is something that is well received. I hope that this is something that continues to spread in the medical community. And I hope people have gained something from this discussion. I hope that people will be motivated to look deeper into the underlying problems with this. And I think that your research is going to be important in the future. And my final question is, what's the vision for this research? What do you have in mind moving forward?
It's really two-pronged research. One is looking at clinical trials to continue to search for how things are related to other things under treatment. In other words, we have a hypothesis about how things work, but we have to do numerous aspects of that in the clinical trials to verify and so on. Then you might think of it as the laboratory side of things, where we're trying to measure those things. We're trying to measure the neuromusculoskeletal response, neurologic response. We're trying to measure the biomechanical changes that occur and trying to quantify as much as we can, the the underlying physics or biomechanics of this issue. And so it's a very complex problem because as engineers, a lot of us are, and some of us are clinicians and engineers, but the point is, in engineering, we like to be able to instrument a structure and measure what's going on as it undergoes its function, whatever it is. If it's a building undergoing earthquake, we like to have sensors on it so that we can see how the forces change over time, what the stresses are. Well, we can't do that with a human being, at least not yet. Maybe we can in the future. So we have to take circuitous routes to get to the same information. And so it becomes challenging. And that's why there hasn't been a lot of definitive research like this in osteopathic manipulative medicine. I hate that term. It just sounds bad. Manipulative medicine. But manual medicine techniques, because we can't, it's hard to reduce the variables that we deal with under these conditions. And we can't unzipper it and put in instrumentation to folks and follow them around while they do things to see what forces are involved. So it becomes a difficult, a challenging kind of an issue. But those are the two basically, clinical research and as much as we can laboratory research to support what we're doing.
Any last words of wisdom before we call the episode here?
Well, if I had any wisdom, I would tell you, but I just don't think I have any.
Well, all right. Folks, we've been talking with Dr. Clarence Nicodemus about his revolutionary approach to the treatment of chronic low back pain. Dr. Nicodemus, thank you for your time.
Oh, you're quite welcome. Thank you for your time. What you wanted.
Yeah, that was perfect. I think